Good evening. I'm psychiatrist Jay Fawver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 26th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call here at the Fort Wayne area by dialing 969-2720, or if you're calling any place across the country, toll free, you may dial 866-969-2720. Now, on a fairly regular basis, I am broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at mattersofthemind, all one word, at WFWA.org. That's mattersofthemind at WFWA.org. And I'll start tonight's program with a question I recently received. It reads, Dear Dr. Fawver, when do you think it's appropriate for a psychiatrist to hand off treatment to a family doctor to monitor medications and progress? Sometimes it's easier for my loved ones to make regular appointments with our family doctor. Well, that's a very good point. Your family doctor has to have a level of comfort with the medication that a psychiatrist is using. So if the family doctor is familiar with the medications the psychiatrist is using, that would be a good start. And you always also look at the complexity of the number of the medications that might be used. If there's 2 or 3 different medications being used in combination and they're still changing, that could be a factor in itself. So you want to be very stable with your medications for at least 3 to 6 months, I would estimate. And after that time, you can ask the family clinician if it's okay if he or she takes over the prescribing of them at that time. But as a psychiatrist, I want to make sure that my door would remain open for that particular patient to return in the event that there were any problems. When people have ongoing recurrent depressive episodes and they finally find the right concoction of medication to work for them, they might want to follow up with a psychiatrist longer. On the other hand, if a psychiatrist is prescribing a medication that's very simple to use, maybe one medication, you've been on the same medication for 6 months to a year, you bet. You can certainly ask the psychiatrist and ask the primary care clinician if he or she can take over those medications at that time. So it's all a matter of comfort level with a primary care clinician. But again, we in the mental health field need to have open access for people to come back because depression is a highly recurrent condition. If you've had 3 or more spells of depression, even if you get well with the traditional medications that have been used, there's about a 1 out of 2 chance that you might get depressed again within a year. So we have to be aware that even when people get well, if they've experienced recurrent depression, where they've had 3 or more spells of depression in the past, they're highly likely they're going to have difficulty within a year, even when they get well, unless we're making little subtle tweaks on the medication. So sometimes we have to make adjustments up or down on the medication doses to make sure they're still working. Thanks for your email. Let's go to our first caller. Hello, Susie. Welcome to Matters of the Mind. Susie, you want to know about seasonal affective disorder. Is it typically is it something you can develop in the springtime since it's typically linked to the wintertime? Seasonal affective disorder, you are correct, usually is manifested by people getting more depressed somewhere between October to April. And it's during those months you have the dark days of winter, and it's associated more with the brightness of the skies than it is the coldness of the weather. Although if it's cold, you're more likely to be socially isolated. You're going to stay inside more, and that too will increase the likelihood of you having depression. If it's cold, you're less likely to exercise unless you live up there in Wisconsin and Minnesota, where they embrace the winter times. They get out and have festivals, and they exercise in the wintertime specifically. So they embrace the wintertime. We're more likely here in northeastern Indiana to get depressed in the wintertime because we get more seclusive and we don't exercise and get out as much. So wintertime is more associated with depression for a lot of people, but there's a few people, it's a small minority of people, who actually get hyped up in the springtime. So they don't get depressed necessarily in the spring and summer. They get more energized. They don't sleep as much. They get more they get more impulsive. They have more racing thoughts. They're more socially intrusive in the spring and summertime. It's extremely rare that people get more depressed specifically in the spring and summer. But that's a very, very small number of people that might get more depressed in the spring and summer. Usually you'll have this pattern where most people get more depressed in the fall and winter. Some people get more hyped up and manic when they get into the spring and early summer. And then a very, very small number of people get more depressed in the summertime. The key in any of those patterns will be to anticipate it. And as a psychiatrist, I'll try to adjust medication accordingly and try to adjust their lifestyles accordingly as well. In other words, if they know that there's a certain time of the year where depression is going to be coming on, well, I would try to anticipate to have them take their antidepressant medication at that time, or maybe increase the dosage. But most importantly, stay socially active during that time, exercise during that time, and if it's in the wintertime, use a light box to wake up the brain during that time. In the summertime, usually it's going to be a matter of socializing, getting out of the house, doing things, staying busy. One of the predictors for staying depressed will be lack of pleasurable activity. So when you start isolating yourself, you don't do the things that used to be fun, you're not enjoying life anymore, that's a predictor that you're going to stay depressed. And there's actually a scale that we use that patients will rate. It's a 14-item scale called the Snaith-Hamilton Pleasure Scale. It's called the SNAPS, Snaith-Hamilton Pleasure Scale. The SNAPS is a scale where we look at the number of symptoms people might have where they're not enjoying life. Either they're not enjoying the sensory aspect of life, the social aspect of life, or just pleasurable activities in general. The higher the score on the SNAPS, the more likely that they're going to have difficulty with getting relapses with depression. So when you start giving up enjoyable activities, it's more likely you're going to have recurrent depression. So we try to keep people doing things that are enjoyable. Thanks for your call. Let's go to the next caller. Hello, Mildred. Welcome to Matters of the Mind. Well, Mildred, you'd mentioned that your child has a fear of thunderstorms. Is there anything that you can do to help them before and during a thunderstorm? Mildred, there's a concept of phobia where you're afraid of something, and it's often an unnatural fear. Most people have an unnatural fear of snakes or an unnatural fear of public speaking, and some people, especially children, have an unnatural fear of thunderstorms. Even though you can be in a safe environment, you hear the thunder and you see the lightning, and it's very scary. Well, the first thing I would do, Mildred, is try to develop a concept called a counterphobia. A counterphobia is where you react just the opposite as you would with a phobia. So with a phobia, you're dreadfully frightened about something. A counterphobia is where you actually embrace a thunderstorm in this case. So instead of becoming fearful of a thunderstorm, get to understand the science behind a thunderstorm. Depending on the age of your child, you can help the child understand the science for what's happening in the sky. Now, granted, with small little children, you can always say the angels are up there bowling. Okay, you can go along that line and kind of make it a fun type of thing. But as the children get older, even 6 years of age and older, they can understand the atmospheric changes occurring in the clouds and what's going on. But now that we have cell phones with applications on them showing radar, you can show them where the thunderstorm is. And it's always fun to count the number of seconds after you see the lightning to the time that you hear the thunder, because there's 5 seconds for every mile when you see the lightning to the time the thunder reaches you. So it tells you, based on the number of seconds, 5 seconds per mile, how far away the thunderstorm may be. Now, we don't have to rely on that so much anymore because we have these apps that show the radar, but you can actually embrace a fear like that. The same can happen with any phobia, Mildred. I'll tell people that, if you're afraid of snakes, go find some snakes that are non-poisonous and handle some snakes. It'll get you over the fear really fast. If you're afraid of public speaking, embrace opportunities to be able to speak in the public. And the more you embrace those kind of challenges, the more likely you'll get over the thunderstorms, the snake phobia, the public speaking phobia. Flying is another common fear that people will experience. But the more the people will fly in a jet fuselage and go different places from airport to airport, they become less fearful of the turbulence they might encounter. So with any fear, it's a matter of experiencing it, understanding the nature behind it, and trying to overcome it with practice, practice, practice. Mildred, thanks for your call. Let's go to our next caller. Hello, Benny. Welcome to Matters of Mind. Benny, you want to know about medications for delusions. Do they actually work? Are they helpful? Basically, Benny, when somebody has a delusion is a fixed false belief, all right? It's fixed because you can't talk somebody out of it. It's a real phenomenon in their mind, and it's false because it's always not true. So a fixed false belief is a delusion, and it's basically a disturbance in this little part of the brain called the parahippocampus. The hippocampus is our memory center of the brain here on the side part of our brain, and the parahippocampus refers to the area of the brain beside the hippocampus. There's a disruption there, and when people are having delusions, that part of the brain is lighting up, and it's giving them a fixed false belief. And it's not uncommon that we'll hear about people having these delusions described as they would a bad dream. So when people are having a nightmare, for instance, Benny, what's happening is the front part of the brain is shutting down. The front part of the brain is the logical part of the brain that tells you if something is really occurring or not. It thinks through the process of what's happening around you and determines if you need to act on that, do you need to flee on it, what should you do about it. So this front part of the brain, when you're dreaming, will just shut down. So when you're dreaming, as you can imagine, you're not logically thinking through the situation. That's why so many dreams will seem very unusual when you awaken. Now, the dreams that you experience at night will be erased within a matter of seconds unless you start thinking about them, unless you write them down, unless you talk about them. So dreams are typically going to be erased, just like a whiteboard, very quickly after you awaken. Well, here's what happens when people have delusions, Benny. Delusions being a fixed false belief, many times associated with schizophrenia, sometimes bipolar disorder. Delusions can give you this ongoing perception things are happening when they are not, similar to a bad dream, only when you're experiencing a delusion in the midst of a psychiatric disturbance, you're wide awake. So when people are experiencing delusions with schizophrenia, with bipolar disorder, any kind of condition that can give you delusion, these people are wide awake and they're having kind of like a wide awake bad dream. And they're going through life having these perceptions, these awful things are happening to them. So what do the medications do? The medications do a couple things, Benny. Number one, they fire up the front part of the brain. The medication we nowadays use for delusions and schizophrenia symptoms and many of the bipolar disorder symptoms will be medications that block these receptors called serotonin 2A receptors. If you block serotonin 2A receptors, you increase dopamine in the front part of the brain, and in doing so, increasing dopamine in the front part of the brain helps you think logically, helps you with concentration and focus, and gives you a sense of determining what's real and what's not real because the front part of the brain is firing up. When people have schizophrenia symptoms, they often have decreased activity in the front part of the brain. So we want to fire that part of the brain up to allow you to more logically think through things. Secondly, you'll not only increase dopamine in the front part of the brain, but you'll decrease and block dopamine in this parahippocampal area. That's the part of the brain that's a bit overactive and causing you to have delusions and sometimes hallucinations. So you're blocking dopamine in this part of the area of the brain, that part of the brain, the parahippocampal area. You're increasing dopamine in the front part of the brain. That's how the newer antipsychotic medications will work, and that's how they can help with delusional activity in many cases. Thanks for your call. Let's go to our next email question. Our next email question reads, Dear Dr. Fawver, I occasionally have depression and anxiety, but there never seems to be a reason why. I have not had a death in the family or a stressful event. I find that I'm most anxious when things are plugging along quite normally. Is this a common way to experience depression and anxiety? When you're experiencing unnatural depression or unnatural anxiety, and it hangs over your head like a dark cloud, and it shouldn't be there, everything, life is good. That means you have what we call a clinical depression. Now, why do people have clinical depression? Number one, there's about a 30% genetic propensity to that. So it has some genetic influence. Secondly, it can be affected by your past life experiences. If you've had horrible life experiences, especially as a child before you're 8 years old, you're more likely to have depression and anxiety later on as an adult. So before 8 years of age, if you had physical abuse, emotional abuse, abandonment, sexual abuse, if you had any kind of traumatic experiences before the age of 8 years of age, that puts you biologically at a higher risk for having this unnatural depression and anxiety as an adult. Now, we use this particular scale called the Adverse Childhood Experiences Scale. Adverse Childhood Experience Scale is known as the ACEs, and there's 10 questions. If you score 4 or more on those questions, based on your childhood experiences of having these traumatic events, you are thereby more likely to have more depression and anxiety as an adult. So there's some predictability there. If you've had recurrent depression over the course of time, the more spells of bad depressive episodes you experience, the more likely you're going to experience them again. We often compare depressive episodes to epilepsy. With seizures, we see the same phenomenon. The more seizures somebody has, the more treatment refractory they become, and the less precipitation is needed for the seizure to occur. So with seizures, if they're recurrent, they're more difficult to treat and they're more common. With depression, over the course of time, recurrent depressive episodes just will hit you out of the blue. Now, there are things that will bring out those depressive episodes. You've mentioned life is pretty good for you, but if you just start doing some subtle things like maybe changing your diet, eating a very, very high carbohydrate diet will actually, in many cases, make people more depressed. Lacking sleep, let's say for a few nights in a row. You had some projects you needed to do at nighttime. For whatever reason, you lost some sleep for a few nights in a row. That can kind of trigger depression. It's kind of interesting that with epilepsy, the same can be true. A change in your diet can sometimes provoke seizures. And with epilepsy, decreasing sleep for a few nights can provoke the seizures. So the same things will happen with depression. So we'll sometimes dissect a lot of that. For many people, their brains biologically will be more prone to having depressive episodes based on the nature of the past depression. So we will always take that in consideration. But if a depression is just coming on out of the blue, that's what we'll often call a clinical depression. Biologically, it's something that we will often try to address with medications, knowing that if you have chronic ongoing depression, and with chronic ongoing depression, it's not getting treated, and you're more likely to have difficulty putting up with stress during that time, your little neurons are getting to be less fluffy. Your neurons are like these fluffy bushes in your backyard, for instance. If the fluffy bushes in their backyard should have 40,000 branches on them, when you get depressed, those little branches on your neurons, just like the bushes in your backyard, kind of shrivel up. And the bushes in your backyard, if it's not very healthy, will go from 40,000 little branches down to 20,000 branches. That's what will happen to your individual neurons in your brain, especially in this area called the hippocampus, that area to which I referred earlier that has to do with the storage of the memory and concentrating. So as your little neurons in your brain are getting less fluffy, you're more prone to depression, you're more prone to misinterpret the environment around you, you're more prone to becoming more irritable, and we call it difficulty with stress resilience. You just have a hard time putting up with stuff. So when that's happening, what we want to do is try to fire up the fluffiness of the neurons. And just in the past 5 years, we've had specific treatments that will increase fluffiness of the neurons very, very quickly. One medication was a nasal spray that came out 5 years ago called Spravato, also known as esketamine. It's a nasal spray that's been found to increase fluffiness of the brain very quickly based on animal studies, but from a clinical perspective, people often will notice that with the use of Spravato, they can get remission of their depression within a matter of days once they start using that treatment. We now have an oral medication called Auvelity that's a combination of dextromethorphan and bupropion. That's a medication based on the high levels of dextromethorphan will affect glutamate in a similar manner as esketamine or Spravato will. And in doing so, it can make the neurons very fluffy within a matter of perhaps hours. So people are getting a very quick and rapid remission from that. So our treatment nowadays for people that have these ongoing recurrent episodes of depression will be to use medications that are affecting glutamate as opposed to perhaps the older traditional medications that are affecting serotonin, norepinephrine, and dopamine. So it's a whole different paradigm in the direction we're going. We expect people to get well within a matter of weeks nowadays with the treatment of depression, as opposed to waiting the traditional 2 or 3 months for them to see significant improvement. So if you have these recurrent depressions, they're coming out of the blue, the first thing you want to do is try to get those in control. And again, think about it as like epilepsy. If you had a seizure spell in the midst of your epilepsy illness, you'd want to make sure that seizure didn't happen again. You want to get it under control, and you want to get it under control now. In the same way, if you have depressive episodes, you want to try to get those under control if they're out of the ordinary. Now, keep in mind, depression, anxiety, anger, apathy, happiness, those are all normal emotions, and we should experience these normal emotions based on life circumstances. But as you mentioned, if you just are getting depressed for no reason and you feel down the dumps, you're not socializing, you're not enjoying life, and it goes on for at least a couple of weeks on end, that's where you really want to get treatment. Thanks for your call. Let's go to our next caller. Hello, Marilyn. Welcome to Matters of the Mind. Marilyn, you want to know, is your doctor allowed to withhold medication if you don't comply with the doctor's instructions? That's an interesting question, Marilyn, because our first role as doctors will be to do no harm. So if we know that a patient is using their medications inappropriately, we don't want to encourage that. Now, what we want to do is try to help the patient taper off the medication. And I'll give you a good example of that, Marilyn. I see a lot of people who have been on a medication like Xanax, alprazolam, for 30 years. And they'll say, I've got to have the alprazolam, I've got to have the Xanax. They're taking higher and higher amounts of it. It's affecting their concentration. They're coming to see me because they're having trouble with motivation, and they're having trouble with a lot of different aspects of how the Xanax might be actually hurting them rather than harming them. It's not responsible for me to have them continue on the Xanax at these high doses. So what I'm going to often do is taper them off. Now, I will not stop it abruptly. That's irresponsible, because if you stop a medication like Xanax or alprazolam abruptly, you can cause somebody to have a seizure, and they're going to feel miserable even if they don't have a seizure. It's a horrible withdrawal to endure. So I'll often look at the number of years somebody's been on Xanax, and I'll use that number of weeks to taper them off. So if you've been on Xanax for 30 years, yeah, I might taper you off over the course of 30 weeks, which is a little bit over 6 months. So I might do a slow tapering. But the bottom line is I need to have you come off of it over the course of time. It's irresponsible for me to simply blindly keep refilling the prescription if I think it's harming you. So that's where you might be discussing things with your doctor. You know, we often hear about that type of phenomenon with narcotic medications. Instead of taking 3 Percocet a day, for instance, somebody's taking 6 and 10. Well, your doctor's not going to necessarily stop the medication abruptly, but your doctor is going to say, look, we got to go a different direction here. You're going to kill yourself if you go higher and higher on these doses. People will inadvertently overdose on the narcotic medications. They just stop breathing. So we can't allow that to happen, but we have to allow a person to safely taper off of medications to keep them from hurting themselves. So that's where you need to work collaboratively with your clinician, as opposed to telling your doctor, you need to prescribe this medication because I need it. Your doctor's going to try to think about your best interest and doesn't want to harm you, but at the same time, you have to be able to safely taper off a lot of the medications. Thanks for your call. Let's go to the next caller. Hello, Jack. Welcome to Matters of Mind. Jack, you want to know if you can take an anxiety medication like Xanax with a pain medication. Not typically, Jack. I might have said that in a different way about 10 years ago, but in the past 10 years, we've realized that benzodiazepine medications like Xanax, Klonopin, Ativan, Valium, Transient, these are medications as benzodiazepines can amplify the effect of narcotic medications. So when we talk about pain medications, you're often talking about narcotic medications, opiate medications. So opiate medications will stimulate this little mu receptor. It's a narcotic receptor. The different receptors are the mu receptors, the kappa receptors, the delta receptors, but the narcotic medications will stimulate mu receptors and give you pain relief. If you use Xanax with a narcotic, it will amplify that mu receptor stimulation by 4 times. And in doing so, Jack, unfortunately, it can also amplify the likelihood that you're going to overdose on the narcotic by stopping breathing. So it's something that across the board, most clinicians are very, very sensitive about that nowadays, Jack, where we will not give a benzodiazepine medication with a narcotic. Now, what can we give if somebody's having anxiety on top of their pain? Okay, we can work around other ways. Gabapentin and pregabalin, not as much likely to amplify the narcotics, even though they will some. We don't like to use those with narcotics, but if we have to, we'd rather use those medications compared to Xanax. Now, gabapentin is also known as Neurontin, pregabalin is known as Lyrica, so we might use those kind of medications. Sometimes we'll use serotonin medications. If you enhance serotonin, you can have a calming effect overall. And some people have too much of a calming effect on the serotonin medications, and they have this phenomenon called emotional blunting where they don't feel happy, they don't feel sad, they don't feel anything. But we can give a little bit of relief with anxiety by giving a medication that's enhancing serotonin. So we do try to stay away from the benzodiazepine medications with the narcotic medications, Jack, because they can amplify the narcotic effect, and that's never a good thing. Now, this is the type of thing that where medicine is changing. It was identified about 10 years ago. That was a bad interaction. So if the physician is prescribing Xanax with a narcotic, not uncommonly, the pharmacist who's dispensing the medication will pick that up and call us out on it. So it's a combination we often don't like to see people using. Now, how about if you're on Xanax, 0.5 milligram 3 times a day, you've been on it for 20 years, and all of a sudden you have an open fracture of your femur because you're in a car accident and you need a pain medication. What will likely happen at that time, Jack, is the doctors will kind of taper you off the medication pretty quickly to keep you out of real bad withdrawal, but they need to get you off the benzodiazepines as you're starting the pain medication. And if they do give the pain medication, it will likely give it to you at a very low dosage, understanding that the Xanax or that benzodiazepine medication will amplify the narcotic effect. Jack, thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions concerning mental health issues, you can write me via the internet at mattersofmind@WFWA, and I'd love to be able to answer your question online. You've been watching PBS Fort Wayne's Matters of the Mind, and it's now available on YouTube. So God willing and PBS willing, I'll be back again next week. Thanks for watching. Good night.
The preceding program on PBS Fort Wayne was made possible in part by
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronMCH.com.